we use for the same lesions. The lesions which are examined in cytology, I mean we take cytology smears to examine the lesions. Whenever we use the cytology, whenever we use cytology diagnosis, we use the term squamous intraepithelial lesion. So squamous intraepithelial lesion is a terminology we use to report cytology samples. So in cytology samples, we use squamous intraepithelial lesion. Squamous intraepithelial lesion in cytology divided into two groups. Squamous intraepithelial lesion low grade, squamous intraepithelial lesion high grade. Okay? So if the lesion mild dysplasia, we call it low grade. If the lesion moderate or high grade dysplasia, we call it high grade. So squamous intraepithelial lesion in cytology. Now, if we decide to take a biopsy from the cervix, if we take a biopsy histopathologic sample to examine, how we report it? We use the terminology CIN, cervical intraepithelial neoplasia. We say mild dysplasia equal to cervical intraepithelial neoplasia 1. Moderate dysplasia and histopathology in the suctions in the histopathologic examination equal to cervical intraepithelial lesion 2. So CIN2. If we have a severe dysplasia in the histopathologic suction, we say CIN3 or severe dysplasia. So CIN in histopathology reporting, SIL in cytology reported. Is it clear for everybody? Please, if anybody is still confused, I can repeat it for 100 times. Okay?
Thank you, doctor.
Welcome. Any other questions? Okay. Can we continue with the placental pathology? You know, in placental pathology, I will focus with you with the most important issues in the pathology side. You know, the placenta or placenta are really related into an important issues in the morbidity and mortality. So placenta is really important in the morbidity and morbidity for both the mother and child. So there are many issues in the mother and child relate to the placental pathology. The placenta is a very, very unique structure. It's so important, unique structure. Why? Because it has two separate vascular supplies from two genetically distinct individuals, the mom and the baby. So it's a really unique structure. It has both supplies from the baby and the mom. At the end of the term, at the end of pregnancy, just remember the weight is about a half kilogram. So usually the placenta is a half kilogram. The lifespan of this organ, which is really unique in its structure, is again, it's unique. Why? Because we have a clear-cut lifespan for the placenta. It's at the end of the gestation, and whenever we get the fetus, that's it. It's end with the time we're getting the fetus. The placenta is the largest organ of the developing fetus. The large organ for the fetus is the placenta. The placenta include both. Let me go to the The placenta has two faces. This is the placenta. You know, this is the placenta. The placenta has the side that is related to the close, or it's facing the baby, and it has the side that is facing the uterus. So this is the placenta. Parts of it facing the baby and the other part facing the uterus. So placenta include placental disc, the placental disc, the umbilical cord, and the membrane. So placenta always three components: the placental disc itself, umbilical cord, and the membrane. Always three components: disc, membrane, and the umbilical cord. The discoid or the placental disc facing both the fetus and the uterus or the uterus itself. So from one side facing the fetus, we call the chorionic cervix, and from the other side facing the uterus, which we call the decidual cervix. So placenta has two faces: chorionic that face the fetus, and decidual that facing the uterus. The amniotic fluid surround the fetus. You know that it's in the anatomic component of the placenta. The fetal blood enter the placenta through the umbilical artery and one umbilical vein. So we have two arteries in the placental cord and one vein. The decidua, this is the decidua. The decidua is the component. The decidua is the component. This is the decidua is the component that separate the placenta from the uterus. And these are the chorionic villi. The placental disc is composed of chorionic villi. So placental disc chorionic villi, we have the chorion that surround the baby, and we have the amnion from inside that it's surrounding the amniotic fluid. Actually, the amniotic fluid is secreted by the amnion. So we have the chorion outside, the amnion inside. Amnion is close to the, or it's facing the baby. The chorion is facing the outer cervix. Chorion, amnion, and so on. So we have two umbilical arteries and one umbilical vein, and we have the intervillus. These are the chorionic villi. This is the amniotic phase that surrounding the baby itself, and it secretes the amniotic fluid. So the amnion, and outside the amnion we see the chorion. So amnion, chorion, amnion, chorion. This is the fetal phase. This is the mom or the uterus phase. The uterus phase, we have at the uterus phase, we have this outside. The uterus phase, this is the myometrium, and this is the decidual. So myometrium, decidua, and with the placental disc. Myometrium, decidua, placental disc. And this is the cord, the disc, and the cord and the membrane. So this is the membrane: umbilical cord, disc, membrane. Three compartments: membrane, disc, umbilical cord. We go to the placental inflammation and infection. We have two paths for the infection: either ascending through the birth canal or hematogenous. So either through the canal or the hematogenous. That's why we see placental inflammation. Now the ascending inflammation, virtually most of the time bacterial. It can be C. mycoplasma, can be C. candida. So the ascending through the canal, usually the ascending infection bacterial, can be seen by the mycoplasma, can be seen by the candida, rarely. Normally, usually it's bacterial. In many instances, localized infection can cause rupture of the membrane and so on. If we have ascending inflammation, the amniotic fluid would be purulent exudate. The color is not clear. So we lose the clear color, see it cloudy with purulent fixed it. What we see if we have chorioamnionites, the most important factor in chorioamnionites is to see the chorion amnion are infiltrated by a lot of neutrophils. So in chorioamnionites, in the ascending type of inflammation, we see the amnions, the chorion are infiltrated by mainly neutrophils. We see some other type of inflammatory cells, but the most important cells actually are the neutrophils. We see histiocyte, we see lymphocyte, we see plasma cells, but the main or the most important cells actually are the neutrophils. So in acute chorioamnionitis, we see inflammation in the chorion, in the amnion by neutrophils. We see neutrophils also extending into the umbilical cord. When the umbilical cord infested by these cells, we call it phenocytes. Usually phenocytes associated with chorioamnionitis. So when we take suctions, when we examine chorioamnionitis, we see inflammation in both chorion, amnion, and in the umbilical cord. So if we see the inflammation in the umbilical cord, we call it phenocytes. Usually phenocytes associated with chorioamnionitis. The hematogenous spread for the chorioamnionitis, it's go through the hematogenous spread. It's hematogenous spread of bacteria and other organisms. Placental villi in this case are the most frequently affected. So if it is through the ascending path, the most important histopathologic findings seen in the chorion amnion and the umbilical cord. If it's through the hematogenous infection or hematogenous spread, the most important part infected or involved is the placental villi. Many infectious etiologies can infect the placenta. We can see syphilis, TB, listeria, toxoplasma, and many other viruses, rubella, cytomegalovirus, herpes, simplex, and others. So all of these can go through the hematogenous spread. The transplacental infection can go into the, of course, into the fetus. You just go through through the clinical lecture with the torch syndrome, where it involves the baby, the toxoplasmosis, other infection, rubella, cytoplasma, and herpes, the torch complex. Remember the torch complex. So here is the placental villi. We see the placenta that is involved by acute necrotizing inflammation. So it depends on the path of the inflammation. If they pass through the canal, the majority of change seen in the chorion, amnion, and the membrane and the umbilical cord. If the inflammation coming through the hematogenous spread, it's mainly at the level of the placental villi. Ectopic pregnancy, ectopic is defined as the implantation outside of the uterus cavity. Majority of cases in ectopic pregnancy actually here in the tube. The majority of the cases, rarely we can see in the abdomen. It can be seen in the within the ovary, but the majority of ectopic pregnancy actually seen in the fallopian tube. So most of the cases of ectopic pregnancy seen in the tubes. It's 1% of all pregnancies are ectopic. It's not that common, but it's really a serious issue. Clinical features of ectopic pregnancy, it present as pelvic pain, sometimes bleeding, period of amenorrhea. This is the trial actually, amenorrhea, pain, abnormal bleeding. Remember this trial, pain, abnormal bleeding, amenorrhea. Right away, we check for the beta HCG, we check for the ultrasound to check for ectopic pregnancy. Diagnosis, in addition to the clinical presentation, we do the ultrasound to check that there is a problem in the fallopian tube. In the microscopic, we see placental tissue or fetal part. Remember, where we see the fetal part and the placental tissue, we see them whenever we take the fallopian tube by surgical excision. While if we check for the uterus in the ectopic pregnancy, let me show you. If we do D and C dilation and curettage in ectopic pregnancy, what we're gonna see? We will not see chorionic villi or we at all. So no chorionic villi if we do dilation and curettage in the ectopic pregnancy. What we see in the dilation and curettage, D and C, in ectopic pregnancy, we see decidua and we see secretory endometrium. Decidua, secretory endometrium. We don't see chorionic villi. We see chorionic villi only in the excision sample when we take the ectopic pregnancy out. Risk factor for ectopic pregnancy, we'll go through them mainly in the clinical lecture. Pelvic inflammatory disease is a very, very important risk factor. Intrauterine tumors and endometriosis. Smoking can contribute to ectopic pregnancy. Congenital anomalies of the tubes, of course, is a risk factor of ectopic pregnancy. Diethyl stilbestrol, not anymore used, is a risk for ectopic pregnancy. Another history of ectopic pregnancy can be seen as a risk factor. History of multiple sexual partner is a risk factor of ectopic pregnancy as it increases the chance of pelvic inflammatory disease. IDC, intrauterine device, it also is a risk factor for ectopic pregnancy. History of infertility is risk factor for ectopic. So all of these risk factor of ectopic pregnancy. Just remember, in 50% of tubal ectopic pregnancy, we don't see any previous risk factor. So in 50% of ectopic pregnancy, the problem is unknown, just an ectopic pregnancy with no previous risk factor. Ovarian pregnancy, as I said, it's really rare. Ovarian pregnancy, gestational within the abdominal cavity, it can be seen, but again, it's really another one which is really rare. So ectopic pregnancy, remember, most of the time in the fallopian tube. Spontaneous abortion and miscarriage, it's a pregnancy that been lost before 20 weeks of gestation. So miscarriage, gestation, or it's pregnancy loss before the 12 after the before the 12-week of gestation. That's what we call the miscarriage or spontaneous abortion. Miscarriage that occur before the 6th week of gestation we call early pregnancy loss or chemical pregnancy. You know all of these terminologies. It's good to memorize and remember in the clinical lecture and be careful are really, really important. So all of these terminology are important terminology and pay attention to them in the clinical lecture. Miscarriage that occur after the 6th week of gestation being called a clinical spontaneous abortion. For us in histopathology, for us as a pathologist, we call all of these as miscarriage or spontaneous or abortion or product of conception at the end. 15 up to 10 to 25% of pregnancy and miscarriage. It's really a very high number. Why we don't see all of these 25% of pregnancy? Because Many of them, actually the majority of them are not by the patient. That's why we don't see them. Causes of spontaneous abortion of miscarriage. Remember, chromosomal abnormality. Actually, chromosomal abnormality is the most important cause of miscarriage or spontaneous abortion. Half of the first trimester have abnormal chromosomes. So the most common cause, especially in the first trimester miscarriage, is the chromosomal abnormality. Hormonal problems, Cushing syndrome, thyroid disease, polycystic ovary syndrome, diabetes, and adequate function of the corpus luteum, all of them as causes or risk factor for spontaneous abortion or miscarriage. Infection, diphtheria is a good cause of miscarriage or spontaneous abortion. Maternal health problem. Remember, the systemic LE is a very good cause of the spontaneous abortion with the anti-phospholipid antibody syndrome. So systemic LE is a risk factor. Lifestyle, drug abuse, smoking, very well-known cause of miscarriage. Maternal age, any maternal long or any old maternal age after the age of 35 is a risk factor or a cause for spontaneous abortion. Trauma, of course, any trauma to the pregnancy or the area is a cause of spontaneous abortion. Abnormal structural and abnormality in the uterus, the Sherman syndrome, where we see adhesions, and Sherman syndrome is a risk factor. You know, the septate, the wedge of fibrous tissue, the septate wedge fibrous tissue in the uterus is a cause. Bicornate uterus, where we see the uterus, it looks like bicornate, is a risk factor or is a cause of miscarriage or spontaneous abortion. What we see in spontaneous abortion, remember what we see in spontaneous abortion, the most important factor in histopathology to confirm the presence or absence of miscarriage or spontaneous abortion is to find the chorionic villi. So if we see chorionic villi in the histopathology, we just say confirm the products of conception. If we don't see chorionic villi, we don't see chorionic villi, we never, ever confirm products of conception. This is a medical legal issue. So confirming the miscarriage or spontaneous abortion, we always need the presence of chorionic villi. What if we see decidua? Is it enough to diagnose product of conception? Absolutely not. Usually we see decidua with the miscarriage or spontaneous abortion. We see decidua, we see secretory endometrium, but in the same level, we see chorionic villi. So remember, chorionic villi is important to the diagnosis product of conception. Now we move to the multiple gestation, twin placenta. Less than 1% of pregnancy yield dizygotic or monozygotic twins. So dizygotic twins, it means that dizygotic or monozygotic fertilization of two ova. If we have a two ova being fertilized, it is zygotic. So dizygotic, two ova. Monozygotic, one ova. So we can have dizygotic or monozygotic. So monozygotic, one ova, two zygotic or dizygotic, two ova. It's very important, you know. If we have two ova, it means two separate, different fetus. If monozygotic mean one ova, it's being divided into two fetuses or into two pregnancy. It's identical twins. So it's really important. It's dizygotic or monozygotic. Dizygotic mean twins, non-identical twins. Monozygotic, it's mean definitely identical twins. So we have multiple gestation, fertilization of two ova in dizygotic, or one ova, we see the monozygotic. Here we have the dichorionic diamniotic twins. Two twins, each of them has different chorion and amnion. So dichorionic diamniotic. It can be chorionic, diamniotic fused. You know here each fetus has his own chorion and amnion. However, it is fused by the chorion only. So dichorionic diamniotic mean two fetuses. Each one has separate chorion, separate amnion, but the chorions are fused. Now the monochorionic diamniotic. Two fetuses, they have one chorion, so they joining one chorion, only one chorion, while each of them has separate amnion. So monochorionic diamniotic. Each fetus has his own amnions, while the same chorion. Monochorionic diamniotic. This is extremely rare. Monochorionic, monoamniotic. So both fetuses has the same chorion, has the same amnion. This is extremely rare. Usually we see these. We see dichorionic diamniotic, dichorionic diamniotic fused, and monochorionic diamniotic. It's extremely rare to see this one, monochorionic monoamniotic. So dizygotic twins, fertilization of two separate ova, it's result in genetically different twin. Can be the same or opposite sex. So it's same or opposite sex in the dizygotic fertilization. Dizygotic twinning is more common in women who has used hormones. It's common in nowadays with the increased use of hormones. Separate placenta develop when two fertilized ova implant. So separate placenta. Sometimes the placenta are fused, but separate placenta. If they implant each other, they can fuse. Microscopic examination of the membrane between the two fetuses shows two amnions and two chorions. So diamniotic, dichorionic in the dizygotic twins. So diamniotic, dichorionic, two separate fetuses. Monozygotic twins, it's not common actually. Monozygotic twins, it's one ova being fertilized. So one ova being fertilized, and this fertilized ova divided to give genetically identical twins the same sex. This is the monozygotic twins, and it depends on the stage where is the division being happened. Pregnancy, preeclampsia or eclampsia, toxemia of pregnancy. Preeclampsia is the development, is a triad, hypertension, proteinuria, and edema. And it is used in seen in the third trimester of pregnancy. You will go through the preeclampsia and eclampsia in details in the clinical lecture. The preeclampsia, hypertension, proteinuria, and edema. If we have a Caesar, so we have full eclampsia. So complex symptoms complex. If we have a Caesar, we have eclampsia. So preeclampsia, eclampsia is still referred as toxemia of pregnancy. It's being called by toxemia of pregnancy. It's been seen in 5 to 10% of pregnancy. It's seen particularly with the first pregnancy or in women in older age group. Etiology is unknown. Most of the time we have insufficient maternal blood flow, so we don't know why we have eclampsia, preeclampsia. Most likely there is an insufficient blood flow. There is some problem in the spiral artery. There is a problem in the remodeling of the spiral artery that can cause insufficient maternal blood flow. What we see, what it's important to, is eclampsia, preeclampsia for us in pathology, is to see that we have a placental infarction, we see hypertension, we see evidence of hypercoagulability, we see organ failure, we see the HELP syndrome in rare occasion. As I said, you will go through this in the clinical uh, lectures. Morphology, histopathologically, we see infarcts, we see retroplacental hemorrhage, we see premature maturation of the placental villi. Just remember the infarction and the fibrinoid necrosis. It's commonly seen in eclampsia, preeclampsia. So infarction, hemorrhage, fibrinoid necrosis, that's all you need to remember in pathology. Infarction, retroperitoneal hemorrhage, fibrinoid necrosis. Normal fertilization, usually normal fertilization, we have two sets of chromosomes, one from the mother, one from the father. We see the sperm donate 23 chromosome and the ova 23 chromosome, and the result is the 46 chromosome. Just remember this because we're going to move to the gestational trophoblastic disease. Is a group of disease that affects the trophoblast. Most of the gestational trophoblastic diseases, because it's proliferation of the trophoblast, it show increased production of the beta HCG as a product of the trophoblast. Serum beta HCG is a very important. It's very important to detect the gestational trophoblastic disease. It's elevated in ectopic pregnancy. Remember that in ectopic pregnancy we see elevation of the beta HCG, and in gestational trophoblastic disease we see the beta HCG sky high. So the beta HCG continue to rise even after the gestational 14th week in gestational trophoblastic disease. Normally in normal pregnancy, the beta HCG go down after 14 weeks. Type of gestational trophoblastic disease, we have benign non-neoplastic trophoblastic disease, exaggerated placental site nodules. So all of these type of benign non-neoplastic trophoblastic disease, actually it's not important to remember these gestational trophoblastic disease. Many times it's clinically not important. So we can ignore the benign and neoplastic disease. What is important in gestational trophoblastic disease is the hydatid form mole and the neoplastic process. What's important in the neoplastic process is the choriocarcinoma. These are the clinically important. So what's important is hydatiform mole and the choriocarcinoma. Hydatiform mole, it's abnormal fertilization, and it's causing excess of the paternal. So from the father, all the genes in hydatiform mole coming from the father. Remember, hydatiform mole genes all from the mother. The most common form of gestational trophoblastic disease, hydatiform mole, it occurs in 1,000 to 2,000 pregnancy. Remember, hydatiform mole is very common in the Asian group. So risk factor, the maternal age before 15 and after 40, ethnic group in the Asian, women with the previous hydatiform mole. So all of this risk factor for hydatiform mole, pregnancy before 15, pregnancy after 40, Asian group, previous hydatiform mole. Hydatiform mole divided into two types. complete hydatiform mole. The complete hydatiform mole comes from the fertilization of empty ova. Empty ova being fertilized with two paternal chromosomes. So two paternal chromosomes. So empty ova means there is no maternal chromosome. Empty ova fertilized by paternal chromosome. The paternal chromosome, we have two sets of paternal chromosomes coming from the father. So two chromosomes coming from the father can cause the complete hydatiform mole. So the complete hydatiform mole usually comes with the 46XX chromosome. Genetically abnormal placenta with hyperplastic. You see that trophoplasts are hyperplastic. The chorionic villi are huge in size, big in size, edematous in size. So the chromosomal check for complete mole always present with the 46XX homozygous karyotype. Can be heterozygous, mean it's coming from another sperm. So one set from sperm, the another from sperm. Usually both of them homozygous. It's coming from the sperm. So usually we get 46XX chromosome in complete hydatiform mole. So here to explain it in an easy way, one sperm 23 comes into an ova with no maternal chromosome. So we have 23 chromosome of the paternal of the father origin. It divided into two. It goes 46 chromosome, and this is the cause of the full or complete hydatiform mole. 46XX paternal. 46XX paternal is the genotype or chromosomal abnormality in complete mole. The uterus cavity is full with these chorionic villi. It's a thin wall villi. This is the way we see the villi. Very thin, big, large size. If we do the ultrasound, we see the ultrasound clear-cut morphology, which we call cluster of grapes. It causes the snowstorm appearance, or snowstorm appearance of the chorionic villi, typical for the complete mole. Treatment, evacuation of the complete mole. What we see, as I said, big villi, edematous villi, and we see cyto as well as syncytiotrophoplastic hyperplasia. This is what we see in the complete mole. Big villi, this is big edematous villi, and it is outlined by hyperplastic syncytio and cytotrophoblast. So edematous, big villi outlined by hyperplastic villi. Partial mole is different than complete mole. Why? In partial mole, we see 69 chromosome. 69 chromosome, two sets paternal and one set maternal. So in partial mole, the issue is we have maternal, we have chromosome, one set of chromosome from the mom, but the problem that we have two sets chromosome from the dad. So we have 69 chromosome, 69 chromosome. This is the most common scenario for partial mole. One set from the mother, two sets from the father. It comes with the 69 chromosome. This is the most common case scenario for the partial mole. Sometimes we get different scenario. One set from the mother, one set of the father, and the set of the father divided to give the 69. So always the end result in partial mole, 69 chromosome, two set paternal, one set maternal. Partial mole, the morphology, the clinical presentation, everything is partial. In the complete mole, we have the beta HCG highly increased. Partial mole, the beta HCG, it's increased but not sky high. The uterus size, it's increased, but not that large, same as incomplete mole. The chorionic villi size increased, but not all the chorionic villi. Cyto and syncytial trophoblasts are hyperplastic, but not the same as in the complete mole. So just remember, in the partial mole, everything is partial, different than the mole. There is a big difference in one issue between the partial mole and the complete mole. Remember this, it's clinically so important. In partial mole, we can see fetus. So if we see a fetus, it's definitely not a complete mole. In complete mole, we don't see fetus. Sometimes in the partial mole, we see fetus. Another clinical importance between the two, the complete mole is a good risk factor for choriocarcinoma. So the complete mole can transform into choriocarcinoma. The partial mole, extremely rare to transform into choriocarcinoma. So the karyotype 46 in complete mole, 69 in partial mole. Villi, as I explained, fetal tissue can be seen in complete mole. We see possibility of choriocarcinoma in complete mole, very rare in choriocarcinoma. Invasive mole, it's just a molar pregnancy that's invading into the myometrium or the uterus. That's it. Just going into the myometrium and the uterus. That's it, the invasive mole. Choriocarcinoma is completely different disease. It's a very malignant disease, and it's the malignant disease of the trophoblast, cytoancestral trophoblast. So trophoblast, either cyto or syncytial trophoblast, both of them get to be malignant in choriocarcinoma. So choriocarcinoma is a malignant tumor derived from normal or abnormal placental tissue. So it's the malignant counterpart of cyto. Syncytial trophoblast is the choriocarcinoma. Choriocarcinoma is a very important, very malignant tumor. Usually choriocarcinoma is seen as a consequences of previous pregnancy, either normal pregnancy or commonly a molar pregnancy. Rarely it can be seen without pregnancy. Choriocarcinoma, remember, it can be seen without pregnancy. It can be seen as some type of germ cell tumor. Remember, germ cell tumor can be a type of tumors either in the ovary or the testicle. So choriocarcinoma can be seen as a sequela without pregnancy in germ cell tumors of the ovary, germ cell tumors of the testicle. It's a very malignant, aggressive tumor, very malignant, aggressive tumor. The beta HCG is sky high. It's aneuploidic in the chromosomal analysis. It goes right away through the lung, into the brain. The good news about choriocarcinoma, it's a treatable disease by chemotherapy. So choriocarcinoma, very malignant tumor, necrotic tissue, bloody tissue. And if we go to the histopathology of choriocarcinoma, we see both malignant cytotrophoblast and malignant syncytial trophoblast. What is important to remember in choriocarcinoma that you don't see at all. You don't see at all chorionic villi. So there is no chorionic villi in choriocarcinoma, just malignant cytotrophoblast, malignant syncytial trophoblast, necrosis, hemorrhage, and so on. So this is all you need to remember in placental choriocarcinoma. Anybody has a question about the placental disease? You just need to remember whatever I have went through in this lecture. You don't need to remember all the details. Just remember whatever is important for you as a third year medical student. Okay? Any question, please? Any question?
In ectopic pregnancy, the only management option we have is removing the fallopian tube.
Sorry, the question is
In, in,
the huh?
in ectopic pregnancy, the only management option we have is removing the fallopian tube. There is no other option.
Most of the time, yes. Most of the time, if we picked up the ectopic pregnancy, we don't think about it right away. We take the fallopian tube. Usually, if it presenting, if it presenting clinically, many times it presents as what looks like as a lesion in the fallopian tube. I don't know if there is any possibility to manage the ectopic pregnancy in early stage, but usually when we pick up the ectopic pregnancy in the clinical stage, when it's really there, it's the best. The best management is to take the fallopian tube.
Thank you, doctor.
You're most welcome. Okay. Thank you, guys. If you have any question, you are free to ask anytime.